I have the pleasure of introducing our speaker. Dr. Hawthorne earned an MD for the University of Kentucky College of Medicine and completed residency in psychiatry at the University of Kentucky Medical Center in Lexington. He is board certified in psychiatry and addiction medicine and currently serves as associate professor of psychiatry at UK. There, he is involved in resident and medical student education, serving as a program director for the Addiction Medicine Fellowship and assistant program director for the psychiatry residency. Additionally, he provides treatment for the substance use disorders at UK Smart Clinic and Beyond Birth Comprehensive Recovery Center. Welcome back, Dr. Hawthorne.
Hey, thanks for having me. So why are we doing this? I mean, I think everybody probably knows why we're doing this, but opioid use disorders are a commonly encountered condition in our population, and it leads to a lot of morbidity and mortality, so a lot of disease and death. MOUD, medications for opioid use disorder, are effective for this, but underutilized, and can really save lives and improve quality of life for patients with OUD. We would hope that, by learning more about this set of medications, we might be able to increase access and lead to better outcomes for the patients that we serve. So today we're just going to review a little bit about each one of the medicines that we talked about last time, just briefly, and then we're going to talk about how you can use these in treatment, or if you're not a prescriber, if you can discuss these medications with folks and refer folks to treatment, that sort of thing. And hopefully this would lead to better understanding of how these medicines work, what the evidence base is to support their use, and ultimately increase utilization of these evidence-based treatments for opioid use disorder. So just the first part of here, we're going to spend 15 minutes or so, maybe just kind of reviewing the highlights of things we talked about last week, so it's fresh in everybody's mind. And if you weren't here, then you've got a little review as well. But the biggest thing to take away, I think, from everything we talked about last week is this, which is that these medications, at least buprenorphine and methadone, decrease mortality and decrease from multiple different causes, leading to an overall decrease of at least 50%. So that's a 50% reduction in death compared to people who are not on MOUD. So that's a huge difference, right? If you can have somebody's risk of death, with the medication, that's a pretty substantial difference. And not only that, but these medications lead to a whole host of other positive outcomes for folks with opioid use disorder as well. So decreased use, decreased injection use, decreased risk of infectious disease, decreased involvement in criminal behavior, increased retention and treatment, meaning that patients are in treatment for longer periods of time, which is a positive thing. And overall improved well-being and social functioning. So there's a whole lot of positive outcomes that are solidly evidence-based when it comes to medications for opioid use disorder. However, these medicines appear to still be pretty underutilized. So there was a large-scale review just a few years ago, this was in 2020, looking at patients with opioid use disorder and whether or not they received one of these three FDA-approved medications, so buprenorphine, methadone, or extended-release naltrexone. And what they found was only about 15% of patients with this diagnosis were receiving these medications. Most of those folks were receiving buprenorphine or methadone, and a small percentage were receiving extended-release naltrexone. But there's a lot of room there, obviously, to increase the number of folks who are receiving these life-saving and really beneficial medications. So how do these three medicines work? We talked about this last time, but I'll just kind of review briefly. Methadone is a full agonist. So what that means is that it binds tightly to the receptor and it works at 100%. And that receptor that it binds to is the mu opioid receptor. That's the main receptor in the brain that's involved in opioid addiction. And so what that does is it sits on the receptor, occupies it, and works with 100% strength. So then in this sort of analogy of like the outlets, the electrical outlet, it's on the one on the far left, where you're just plugging the thing straight into the outlet, and 100% of the charge, I guess, so to speak, flows through that. When it does that, it decreases withdrawal symptoms, decreases craving, and helps patients to sort of free up their brain, really, to focus on other aspects of their recovery in their life. like work and relationships, and just a full spectrum sort of full recovery. So that's methadone, right? It works primarily by stimulating that receptor to 100%. Naltrexone is at the other complete end of the spectrum of these three medicines. And so naltrexone binds tightly to the receptor, but does nothing. So it doesn't stimulate the receptor at all. So it has like 0% activity there. And it's the same receptor, it's the mu opioid receptor. And what that does is it's in this analogy here, it's like a plug, an outlet cover. You just put it on the outlet and it doesn't do anything, right? It keeps things from getting to the outlet. Medication keeps other drugs from getting to that mu opioid receptor. So it prevents intoxication. It prevents people from getting high. So it's a kind of it's a barrier to use. Doesn't reduce withdrawal, doesn't reduce craving. At least there's not good evidence that it reduces craving. And so, it has benefits, but the main benefit is that it sort of like functions as a barrier to prevent use from occurring. Kind of a complicated medicine to use because you have to withdraw or detox right off of opioids before you can start this. And sometimes for as long as 7 to 14 days, which is difficult for patients to do. And that's a hurdle to starting this medication that makes it somewhat difficult to use in clinical practice. Also, like I mentioned, it doesn't treat withdrawal, doesn't really reduce craving, and it doesn't maintain dependence on opioids either. So that if you suddenly stop this medication, you can be at an increased risk of overdose. And then, buprenorphine is sort of in the middle between those two extremes, right? Where the one medicine activates the receptor to 100%, the other one is it's like 0% activity at the receptor. Buprenorphine is like 40 or 50% activity at the receptor. So it binds tightly to the receptor, but it only works. It's sort of like a dimmer switch, like it's like half strength. And that's in this analogy here. That's the middle picture, right, where it's being plugged in through a power strip. So it's like it's working, but it's only working at like 50%. It reduces withdrawal, reduces craving, helps patients not use and focus on their overall well-being and recovery. Also blocks the receptor, and so does methadone, from other drugs getting to the receptor. So difference in how they work, and difference in some of the details of what these medications can do for patients. And that's just sort of a brief review of things we talked about last time. Extended release naltrexone, like I mentioned, is a competitive antagonist. That just means it's a blocker. Like I said, it doesn't treat withdrawal, but doesn't cause withdrawal when stopped, right? Because it has, again, no activity at the receptor. And it has proven benefits in decreasing illicit opioid use and enhancing retention and treatment compared to treatment as usual, compared to no medication. And it does have, those barriers I talked about just a second ago to its use, right? It's difficult to start because you have to completely withdraw from opioids before you can begin for 7 to 14 days is what the manufacturer recommends, depending on how long lasting the opioids you've been using are. So that's a barrier to starting it. And then when you stop it, right, it does not maintain dependence. And so tolerance may have disappeared while during the course of treatment with extended release naltrexone, putting patients at increased risk of overdose if they go back out and start using the same amount of opioids they were using before treatment. Buprenorphine, like I said, partial agonist of the mu receptor, decreases craving, treats withdrawal symptoms, prevents other opioids from getting to the receptor and binding, and he actually will shove sort of other opioids off the receptor and keep them from working. And only has that 40% intrinsic activity at the receptor. So it can suppress respiratory drive like all opioids can, but it only does so at a limited amount, right? It's unlikely that buprenorphine by itself is going to result in accidental overdose by respiratory suppression. So there's sort of a ceiling effect, like that effect only goes up to about 40% and then plateaus and doesn't get any worse, making this a safer medication than full strength opioids, substantially safer. It maintains physiologic dependence, so there is that protection even if patients stop, that their tolerance hasn't entirely evaporated if they go back out and use again. Has a secondary mechanism of action where it's a kappa opioid blocker. It's a different kind of opioid receptor. That helps to decrease the stress response may have some benefit from mood symptoms and helps to decrease stress-induced craving and stress-induced drug-seeking behavior. Typically, it's combined with naloxone, which is, the brand name is Suboxone. The most common brand name is Suboxone. And that's a deterrent to misuse by injection and snorting. But there is a generic form of that available also, pictured here in the little picture. In addition to the benefits I just mentioned, in terms of, treating withdrawal, craving, blocking things from getting to the receptor, it has evidence that it decreases mortality by at least 50%. And this is a figure showing that it keeps people in treatment, right? Which is a positive thing. I think you want folks to stay in treatment for a long time. I think the longer people stay in treatment, the more likely they're going to have sustained recovery. And so if you look at this top line, that's buprenorphine patients. And so you see some dropping out. It looks like 5 dropped out total over the course of this year, right? 350, 360 days. Whereas the people who are not on any medications, almost all of them dropped out within the first few weeks of the study. So buprenorphine did a much better job of keeping people in treatment as compared to, no medication. Methadone is the last medication we talked about last time, and just as in review, it's a full agonist at the receptor, at the mu opioid receptor. It occupies the receptor, prevents other opioids from getting there, prevents them from working, reduces craving, treats withdrawal symptoms, and maintains cross tolerance. So maintains, physiologic dependence upon opioids, again, which can be protective if patients suddenly stop treatment and go back out to use. A barrier to its use, or there's a couple really barriers to its use. It takes a long time to titrate the dose up to an effective dose. So there's a period of several weeks at least where patients are in treatment, but they're on a dose that may not be fully effective for them yet. So that's kind of a risky period of time at the beginning of treatment with methadone, where patients can be at increased risk for ongoing use and accidental overdose. And you can't prescribe this, right? This is only available through methadone clinics, right? Federally licensed opioid treatment programs, and from which can dispense it. And typically that involves patients, as you guys probably know, going to the clinic every day to receive their methadone dose, which is typically liquid to prevent misuse and diversion. But there's solid evidence this works for a whole host of outcomes, like we talked about just at the early part of the slides, in terms of decreasing mortality, decreasing use, decreasing injection use, infectious disease acquisition, criminal behavior, improvements in retention and treatment, improvements in psychosocial functioning, all kinds of things. And it's been used for 50 years or so for heroin and opioid addiction. So well-established, really solid evidence base for its use. And just to summarize, there's what treats withdrawal? Methadone and buprenorphine treat withdrawal. Naltrexone does not. Methadone and buprenorphine also decrease craving, have some variable benefits for pain, and which, neither one of those things does naltrexone do. You see this asterisk here with the cravings for naltrexone. It's a little debatable, I guess, but I don't think there's really solid evidence to say that it actually decreases cravings for opioid use. It seems to for alcohol use, but not necessarily for opioid use. Again, reduction in infections associated with use and with injection with methadone and buprenorphine, reduces crime, right? And save lives. So there's the mortality data really is for buprenorphine and methadone. So the reduction, the 50% at least reduction in mortality is for buprenorphine and methadone. It's kind of an open question whether that's true for naltrexone or not. We don't know. It does have evidence that it can decrease use, but we don't know for sure. We don't have the evidence base really to prove that it's going to reduce mortality in the same way that buprenorphine and methadone have done. And there's that concern, right, about overdose when people stop treatment with naltrexone. You see here that this withdrawal needed line, and really that kind of gets to the difficulty of starting naltrexone. You got to withdraw first for 7 to 14 days before you can begin it. That's not really true with buprenorphine or methadone. Typically with methadone, you just show up at the clinic and have not used maybe that day, or maybe having used that day, depending on how the patient actually presents. But there's no prolonged period of time for which patients need to detox off of opioids before they can begin methadone. buprenorphine requires a very brief period of time, typically, where patients are not using, but that may be as little as 12 to 24 hours, right, to safely start buprenorphine. And new ways of starting buprenorphine have been developed that patients don't have to stop using at all, so that they can begin buprenorphine with you may have heard of like microdosing induction. So that's a method of starting buprenorphine that does not require them to stop using the opioids they were using before they can start treatment. So they can just seamlessly begin treatment. So there's, that barrier there is to initiation of treatment is really there with naltrexone. But anyway, these 3 medicines are FDA approved, evidence-based to varying degrees and different outcomes for use of opioid use disorder. They all work the mu opioid receptor, but in 3 distinct ways. Methadone's a full agonist, buprenorphine's a partial agonist, and naltrexone is an antagonist, blocker. And they have all kinds of improvements. At least buprenorphine and methadone have decreased mortality and all the things we've mentioned before, right? There's a lot of positive outcomes. I don't want to keep repeating the same thing, but there's a lot of positive outcomes for these medications. And they really should be an integral component of treatment for patients who have opioid use disorder. So there were some questions that were sent in last time, and I'll kind of just go through those. And if at any point somebody wants to interject with a new question or kind of clarify what we're talking about here with the question on the slide, let me know, and we can do that. So the first question was about allergies to naloxone or naltrexone, and I think this is something that comes up. Especially in my experience anyway, it comes up when when you're talking about beginning buprenorphine, the combined product, the buprenorphine naloxone combined product. And patients will say, I can't take that, I'm allergic to naloxone. And that always kind of raises the question in the mind of the person prescribing the medicine, is that real? What does that mean? And what should I do about it, right? Because if a patient has a real allergy, a true allergy to naloxone, which is possible, but rare, then you probably shouldn't use the combined product. You should just use some other medication, or you could use just buprenorphine by itself. The downside to that, right, is that buprenorphine by itself is more likely to be misused, abused, and diverted than the combined product of buprenorphine and naloxone. So you're kind of, as a person prescribing the medicine, you feel like you're in a kind of a bind there. You want to do what's right and best for the patient, but there's a lot of things to consider, right? So the question came up of like, what does an allergy to naloxone actually look like? And so, the allergy, and so we're trying to like distinguish here between allergy symptoms, like a real allergy, an adverse reaction that's a known possibility with the medication, but it's rare, and side effects, which are, things that are bothersome, but, are kind of known and happen fairly often, with medications, and may not require stopping treatment, right? And so there's a spectrum there from allergy, which may be very severe, right, to adverse reaction, which may or may not be severe, depending on what happens, but is a known possibility with the medication, and side effects, which are known possibilities with the medicine that are typically bothersome and, may want patients to talk about switching, may lead patients to ask about switching medications, but they're not dangerous usually, or something that is going to be an emergency. So an allergy would be things like a rash, right? That you can see and observe, like an objective rash that the patient has, hives, swelling, or like an anaphylactic reaction where they have difficulty breathing, the airway constricts, or they have swelling of their mouth and throat and that sort of thing. That's what an allergy is like. Other end of the spectrum, right, would be things like nausea, poor appetite, headache, fatigue, sleepiness, sleep problems, those kinds of things would be side effects. Withdrawal symptoms, right? If you begin either one of these medicines, naloxone or naltrexone, too soon after somebody has used their last dose of opioids, you can precipitate withdrawal. Because what both of these medicines do, naloxone and naltrexone, is they get to that opioid receptor and they kick everything else that's on the receptor off, right? So if somebody's intoxicated on heroin, let's say, and then they get naloxone, right? It's going to go to the receptor, the naloxone will, and it's going to move the heroin off the receptor, and then the patient will go into withdrawal because they're no longer getting that effect of being intoxicated on the heroin. So both naloxone and naltrexone, if they're begun soon after last use, can precipitate withdrawal. And that's really a known feature of the medication. That's not that's not an allergic reaction, right? Nausea, poor appetite, headache, sleepiness, none of those are allergic reactions. Those are known side effects of the medications. And in the middle are adverse reactions, things that are concerning and may lead you to think about switching medications, but are not really an allergy. So they're not something that's caused by the medicine interacting with the patient's immune system, really. So depression, like with naltrexone, and suicidal ideation, that's a possibility. It's not very common, but at least it's in the literature about the medication. Liver inflammation, right? Although typically that's at super therapeutic, so extra high doses of naltrexone, higher than we really use to treat opioid use disorder. But that's something that's been reported in the literature, and we know that's a remote possibility. Again, typically only happens at like very high doses of naltrexone. And then injection site reactions. So if you give an injection of anything, right, you can have some redness, you could have some swelling. There's a remote possibility that you could have an infection, right, from an injection. So there's itching, pain at the injection site. Those are all kind of common, more or less common injection site reactions. So that kind of hopefully helps distinguish, allergy, which can be, is something that's caused by the interaction of the medicine with the patient's immune system, right? And that might be like rash, swelling, anaphylaxis. It can be an emergency. Distinguish that from adverse reactions that are known consequences of the medicine, and just some side effects, which can be common bothersome things that happen with medications. But you can have allergies to both of those medications. It's entirely possible. But in terms of like making treatment decisions, this helps, I hope, to help distinguish kind of what the patient's talking about. Because if they say, well, I have an allergy to naloxone, I took Suboxone combined with naloxone one time and it made me sick. And then you ask them questions and they say, well, I was using at the time and I took it and it basically caused withdrawal symptoms. That's not an allergy, right? Nausea, similarly, not an allergy. So yeah, helping to distinguish those things is important. And I think if you are going to make treatment decisions based upon this, it's good to have some supporting evidence from previous folks that have treated the patient, if that's available, like previous documented allergies to naloxone or naltrexone, or an observed allergic reaction to one or the other. That's the most useful, probably, and most reliable kind of information you can get about this. The second question was about how can you help clients make the best choice between medications for opioid use disorder? And so that's a good question. And there's options, right? So we've got at least 3 options that we've talked about today and last week. And they differ. I mean, there's overlapping benefits here in the medications, but they do differ in terms of how they work, specifically what the patient will experience, and the benefits they can hope to get from the medication, and the treatment setting in which they can receive the medication, right? So there's differences, right? So you got to kind of take all that into consideration. The first thing I think you want to do is just provide education, right? Educate the patients about the options, right? Some of the things we talked about today. There's methadone, right? There's buprenorphine. There's naltrexone. They each have their own benefits and strengths, right? They each have their own sort of downsides, and kind of provide some sound education that's evidence-based for the patient to help guide the discussion and the decision that you guys will make together. I think it's important to consider, what's the likelihood that the patient's going to be able to access this treatment, right? So methadone is only available through opioid treatment programs, right? So they're not on every corner, although there are lots of them throughout the state, but they're not everywhere. And then that may not be accessible to every patient easily. And it may be difficult for some patients to commit to go into a clinic every single day to receive their dose. So sometimes that's a barrier, right? Similarly, extended release naltrexone, right? Sometimes there's a barrier there in beginning it, because if a patient is not in a hospital, not in a rehab program, they're just kind of out at home or whatever, it may be really difficult for them to not use for that 7 to 14 days that's required to begin extended release naltrexone. So that can be a barrier. But those are things to discuss with patients, I think, right? In addition to the evidence base about how these medicines work and what they can hope to benefit from the medication. And then just kind of get from the patient, what are their goals for treatment? Like what do they value? Like, what's the most important things to them? Because that'll help the both of you kind of decide together what is the best course of action. And I think an important thing to think about in that is the role of stigma, because I think there's varying degrees of stigma for these medications, right? And I think that sometimes people will come into treatment with a bias against methadone, or a bias against buprenorphine, or maybe a bias against extended release naltrexone. But is there something there that's the patient is sort of a bias that they're bringing with them, that they've learned from previous treatment providers or who their peer group or whomever, about these medications, and kind of address that too, so that hopefully they can be a little free of that and make a decision based on the evidence and based on what would be best for them and their recovery. I mean, I do think you want to underscore the mortality data, right? Because that to me is, that's like the if you don't have that, if you like that's the most important thing, right? Is this going to help you stay alive or not? And both methadone and buprenorphine, we have good evidence to say that those really do. So I think that's something that's really important to talk about in terms of risks and benefits with patients. And then it needs to be a collaborative decision. I think you got to take all this into consideration and help the patient to make a decision that's going to help them take the next step in their recovery. Okay? So are there studies that show how long people should stay on MOUD? Yes and no. So there are studies looking at outcomes with MOUD, and there's some that are fairly lengthy. There's nothing that says in the literature that this is like the magic amount of time that you have to stay on this, after which you're cured and things are all better and you can stop treatment and go on your way. So there's no point at which you can say, based on the evidence, this is the minimum amount of time you need to stay on this, in terms of before this time you were at risk and after this time you're not at risk anymore. So yes and no. We're going to talk about some of the data here in a second, but generally the trend in all the literature is that the longer you stay on it, the better, right? The outcomes across the board improve with time, more and more time on treatment, or on medications for treatment. Decreases all kinds of different risks, including mortality risks and all the risks we talked about before. And it enhances, the longer you stay on it, the more likely you are to continue with treatment, right? So that and receive other kinds of treatment besides MOUD, right? You're going to receive medical care, psychiatric care, psychosocial support, all kinds of different things, the longer you stay in treatment. And we do know from the data that early discontinuation leads to increased risk of use, overdose, and death. So there is no magic timeline. And really, if you take those 3 points together, right, that we don't have a time point at which we can say you're cured and don't need treatment any longer. The longer you stay on it, the better your outcomes will be. And that really, if you stop too soon, you're putting yourself at risk. Take those 3 things together, then maintenance treatment is really the outcome that you kind of come to from that, right? I think that's the conclusion you reach, right? Is that maintenance treatment is probably the best option, and that's kind of become the guidance from places like SAMHSA and things like that. That for many patients, maintenance treatment, ongoing open-ended treatment with MOUD is probably the best option. So we'll look at some of the studies and some of the data about this. So this is from this year, actually, just a few months ago. It's a study that looked at Medicaid data, and in 11 states, including Kentucky, and mostly this region of the country. And what they did was they looked at overdose risk in 2 groups: people who were on MOUD and people who had been on MOUD and stopped. And so when they looked at the risk of having an opioid overdose, okay, in those 2 groups. And so what they found consistently is that the MOUD, the group that had continued in treatment, that had continued being on MOUD, had a substantially lower risk of overdose as compared to the patients who had been on MOUD but stopped. right? So MOUD decreased the risk of overdose, which is not surprising. It's been found before. But an interesting thing they found here is that that benefit improved with time, right? So so you can see the intervals here. So they looked at these two groups at 60 days from the beginning of the study, 120 days, 180 days, and 300 days. And what they found is that the hazard ratio just kept getting smaller, right? The longer the patients were on it, right? So if you stayed on MOUD for 60 days, your risk of having an overdose was only 39% of what it would have been, if you had dropped out of treatment, right? At 120 days, it was only 34% of what it would have been if you had dropped out of treatment, and so on and so forth. So what they said was that the hazard of overdose continually decreased the longer patients stayed on MOUD, and was approximately 10% lower with each additional 60 days of MOUD, right? They didn't follow out beyond that that I'm aware of. So we don't know definitively, I guess, beyond that. Does this trend continue, right? Does it ever does it keep going down? I think probably, at least, based on some other data that we've seen. But but the takeaway here is that MOUD reduces overdose risk, and that benefit increases over time, right? This is just a summary, sort of like, of a lot of data here of looking at mortality rate, standardized mortality ratio. So it's like likelihood of dying, right? Basically, is what that means. And so if you say that the general population risk is 1, right? Then people who have an opioid use disorder and are on treatment, on medications for opioid use disorder, their standardized mortality ratio is like 1.8. So that means that from any cause, they're just 1.8 times as likely to die as the average person. But if you look at people who have opioid use disorder but are not in treatment, not on medications, right, it's over 6. They're 6 times as likely to die as the general population. So that's a huge difference, right? It's like a third of the risk, maybe even a little bit less than that. So again, really enormous difference here in terms of mortality risk for patients who are on MOUD. And we know that when patients stop, right, that their risk of overdose increases, like we just talked about in the study before that, 2 slides ago. And so it's really important to note, like, which medications keep people in treatment the best. And really, if this is from Medicaid data. Actually, I'm sorry. Some of this is from Medicaid data, and some of it's from PDMP data. But anyway, the buprenorphine community retention rate. So, did they stay in treatment 180 days or longer? Right, is 64%. Methadone, that same time frame, 180 days of continuous treatment. How many people actually stayed in treatment that long? 74%. Extended release naltrexone was not good. It was like 10%. Some of that is the barrier of beginning it, I suspect. But again, methadone and buprenorphine had really high retention rates for folks who were receiving those medications. And that's good, because the longer you keep people in treatment, the more likely they are to have full functional recovery, not just not use, but overall, overarching recovery in the multiple different areas of their life, right? So keeping people in treatment reduces the risk of relapse, helps them meet their goals, that helps them to get engaged with a counselor or a therapist or a psychiatrist working on mental health problems and trauma, right? It helps them to build back their social network and hopefully have a network of folks around them that's not using and not engaged in substance use, repair relationships, address legal issues, get medical care that they might have neglected during, active use, all kinds of things. Keeping clients in treatment is part of the goal, right? Because it leads to a whole host of positive outcomes for folks. So what's the takeaway, I think, from all that? And there's more out there that you could say about it, but a lot of it, kind of keeps coming back to some of these same points, right? That staying in treatment longer is better than shorter. There's no magic timeline at which you can say somebody is well and no longer needs treatment. And that ongoing treatment may be the best option for many patients. So this is from SAMHSA for the treatment improvement protocol on medications for opioid use disorder. And what they say is that the best results occur when the patient receives medication for as long as it provides benefit. For many people, just as me as an aside, for many people, that's a long period of time, years, right? And this approach is often called maintenance treatment. And they really discourage arbitrary time limits on the duration of treatment with opioid use disorder. They say these are basically inadvisable. And I don't think the evidence really supports arbitrary time limits on the duration of treatment. To summarize it kind of succinctly, I think patients should take medications as long as there has been a benefit to them. And that you shouldn't be, at least I think the evidence indicates that you should not be enforcing patients to stop medication for opioid use disorder treatment early, and maybe that should just be an ongoing maintenance kind of treatment plan. Next question was about somebody who's concerned about long-term effects of these medications. So how would you respond to somebody who's concerned about long-term effects of buprenorphine, methadone, or naltrexone? Well, the first thing I do is just kind of clarify, what are they worried about? Is this something that is a real possible effect of the medication, or is this something they've heard from someone that's not really something that happens with that medication? So are they concerned about known side effects like, constipation with buprenorphine or methadone, or maybe depression with naltrexone, an adverse reaction, that can happen with naltrexone, real things that can happen with the medication, don't always happen, but can happen, or are they worried about things that are just not realistic concerns with the medication? So you clarify what they're worried about, right? And then you provide education about the relative risks. We've talked about a lot of those today and last week as well. I kind of go back through all of that, but just provide education about what are the real possible side effects and adverse reactions that can occur with these medications. I think that sometimes underlying this question, there's some like internalized stigma the patients are expressing to you kind of indirectly, right? Because I think they don't want to see themselves as somebody who needs a crutch, or they don't look at it. Sometimes patients will not look at time when they're being treated with MOUD as quote unquote real recovery, right? And so those are, it's a real conversation you got to have with the patient, right, about that. But I think sometimes the stigma that patients have sort of taken on from their peer group, or previous contacts with the treatment system or something, makes them think that long-term treatment with these medications is inappropriate or really dangerous. And that's just not the case. And just to kind of underscore it again, right? Untreated opioid use disorder, or people who stop MOUD are at really increased risk of mortality from a number of different causes, including from overdose. And so these medications, although they have some risks, all medications have some risk. These are much safer than untreated opioid use disorder, right? And we've reviewed some of the mortality data here today, but that's a finding that keeps coming up in the literature, right? That the mortality, morbidity risks associated with untreated opioid use disorder are much greater than any risks that might be associated with use of the medication.
Dr. Hawthorne, I have a follow-up question that someone sent me, and it's, do you have any info on whether decreasing dose to lowest effective dose is best practice?
No, not at my fingertips. And I think, what medicine, do we know what medicine they're talking about?
I do not.
Okay. Well, depends on what you mean, I guess, a little bit by most effective dose. So for buprenorphine, for example, we know that it works well when it saturates the opioid receptors, right? When it saturates more than 90% of them. So it's occupying most of the mu opioid receptors in the brain. To get to that dose, for most people, that's around 16 milligrams a day, right? So that's a typical treatment dose, right? And it's a really common dose that you guys have probably seen. You start going less than that, then you have to wonder about how effective that is. I think that the data really supports doses of at least 16 milligrams for buprenorphine to be effective. Treatment doses for methadone are often 80 milligrams or more. And the naltrexone, extended release naltrexone, basically has a single standard dose, right? It's an injection right? That comes, from the, sort of pre-made kind of, from the manufacturer. And so it has 380 milligrams once a month. So that's really, you can't really adjust that very easily. Going below those doses for buprenorphine and methadone, yeah, you start to run into the risk of decreased efficacy. So I guess it depends on exactly which medicine you're talking about and what you mean by most effective dose. Certainly, you want to have a patient on a dose of buprenorphine and methadone that has eliminated withdrawal symptoms and decreased craving substantially for it to be effective. And that typically occurs at the doses I was just mentioning just a few minutes ago. So I think that sometimes, yeah, somebody else had a question. Jerry,
I'm sorry, I didn't mean to interrupt you.
go for it.
That question was actually my question,
Yeah,
and you really did answer it, but I wanted to just kind of give additional information as to why I asked that. Because we have kind of been told, our clinic has been in operation since 2013. So there's been a lot of changes, a lot of research, a lot of information that has come down the pike since that time. But we've always been kind of gotten just the general information that we should be tapering these patients, that we should be getting them to a point of at least lower dose, or taper them off if that's possible.
yeah.
And what we have learned, everything you've said up to this point is I mean, you're
Or
just
the opposite of that.
well, no, not really. No, not really. But you're just right on point. What we have learned about being in,
Okay.
being in the trenches with people, and watching them go through treatment and being on the medication and that kind of thing. So I appreciate everything that you've said, but I just kind of wanted more information as to what your belief and in your studies has shown.
Yeah.
Is taper effective, and is that something that we want to do? But what you said is that 16 milligrams is what is most effective, and when you back off of that dose, then you're going to be at risk.
Yeah. Well,
And
everybody metabolizes medication slightly differently. So
right,
that number may not be the exact same for every single person, right? But
right,
that's a common, sort of treatment number that's or treatment dose, I should say. And then for methadone too. I mean, the 80 milligram plus, it's a common.
well,
Dose.
and Kentucky state regulations, 16 milligrams is kind of the standard.
Yeah.
And then, but the providers have the ability to go, one way or the other, depending on what the patient needs. So,
Yeah. And as far as I can talk about my experience with tapering. My experience with that is that patients. So I generally discourage that. If unless a patient really wants to do that and they see that as their next step in recovery, right? And in which case, we work with them. I try and, I think it would really discouraged if they're not in a good place in their recovery. But if they've had sustained recovery for years and they're engaged in, some sort of recovery program, 12-step or whatever kind of thing helps them. And functionally they're doing well, from a psychiatric standpoint, they're doing well, relationships, employment, all this stuff is well and stable and all that. And then, maybe if they really want to do it, then we can kind of start slowly backing off. My experience with that is that when we start going down, a lot of patients decide they don't want to do that because they get to a point where they start to feel the craving again and the mental obsession, and then they get scared and makes me nervous too. So then a lot of times we end up going back up to a treatment dose anyway. But and then the patients I've seen lots of patients who against our advice, really wanted to stop the medication soon, right? Even as soon as, a couple months into treatment. And typically what happens then is they go back out and use again. And then if we're lucky, they come back to treatment. But so that's kind of what we've seen. I got other questions here from I'm not sure I'm going to say your hand correctly. Phaeton.
Yes, that's correct. Hi, Dr. Hawthorne. And actually, I'm working on buprenorphine treatment for my dissertation. And one of the study is about the dose of buprenorphine. And you just mentioned that greater than 16 are seen like the most effective. How do you define like the effective? Is it about reducing the opioid use or retain the patients or other like outcomes? Thank
All
you.
of that really, as well as reducing craving. Depends on what you're looking at, what kind of study you're looking at. There's going to be variable outcome study, but
Yeah.
yeah. But all of those things would be of interest, right? Use, mortality, retention, and treatment, subjective craving experience, all of those things.
Yeah, we are trying to look at the opioid overdose deaths. And do you know like any evidence from that?
Based on relative to dose?
Yes.
Oh man, not off the top of my head, but I could probably find that if you wanted. Yeah.
Yeah, I'm curious because I did some literature review, but I didn't find it. So I wonder, like, is anything like in your mind about the relationship between those and overdose deaths?
Yeah, I mean, there's a good Cochrane review from a few years ago where they go through a lot of this and talk about the dosing and the dosing strategies and the relative efficacy of buprenorphine and methadone. So that might be, I could look and see if that actually contains what you're asking about. It might.
Thank you.
All right. And then Katrina also had a question.
Yeah, actually, it's more of a comment in response to that practice of tapering. Working in pain management and palliative care and then coming into addiction medicine, I think a lot of, especially with Kentucky regulations, it comes from what we learned, kind of opposite with opioids and pain management, where it was that higher doses were not effective and it did not serve people well. And then, there was the practice of trying to taper, and definitely in chronic pain management, we would want to taper to lowest effective dose. But these can be different things, and it could be the same. But also, a lot of people with opioid use disorder may be more in that mild opioid use disorder in the context of chronic pain. And for them who have a very mild opioid use disorder, did not have injection use, did not start buying other people's opioids, were more like running out of their own, but it's mild. That person probably can get away with a lower dose, but that's different from the person who is a risk of overdose, injection, using other people's opioids, heroin, and definitely now that we're talking about fentanyl, and you have so much tolerance, such a higher tolerance, that 16 milligrams for people who are dependent on fentanyl may not even be enough for that. And so they're all called opioid use disorder, but those are very different on, what opioid use disorder looked like for that patient, just kind of like the insulin dependent brittle person with diabetes versus the person managed with glucophage. They're both going to need to be on some kind of medication and treatment all the time, but it's a big spectrum. So it's not a one size fits all. But for the risk of overdose, we're really talking about the people who are using heroin, fentanyl, buying pills that are not being prescribed, not just, running out of their own medication. So I think that's where that conversation comes from, in my observations.
Yeah, I think you're right. I agree with what you're saying. I mean, there is a spectrum, right, of severity, and the decision about dose needs to be made like in a patient-centered kind of way. Taking everything into consideration about the patient's condition. But I think just the sort of blanket policy of we need to taper everybody quickly, or we need to get everybody down to very small doses of these medications. I don't think the evidence supports that. All right. So then the next question was about how do you switch from one medicine to another? And, I guess thinking about how these work, that can be a little complicated. So this is from the ASAM practice guidelines. But we can just talk about each one individually, right? So say somebody's on buprenorphine and they want to switch to methadone. That's really pretty simple because you're switching, if you think about it, you're switching from that partial agonist to a full agonist, right? Maybe you need to think about using, monitoring closely at the beginning that you're not overdosing the patient with methadone, since it is more potent, right, than buprenorphine. But you don't have to detox off buprenorphine or anything like that. You can stop buprenorphine and begin methadone, right? If you're going from buprenorphine to naltrexone, that's a little more complicated, because again, you have to come off of opioids before you can begin naltrexone. And what I'm talking about here is the standard guidance. There are things that are in the literature about ways you can sort of get around that, and various induction initiation protocols for naltrexone that are complicated. But the standard thing is that you would have to detox off of buprenorphine and for 7 to 14 days before you could give naltrexone. And if you remember, you can start with the oral naltrexone just to see if you're going to precipitate withdrawal before you give the shot, or you can start with a dose of naloxone to see if you're going to cause withdrawal before you give the extended release naltrexone injection, just to make sure it's going to be okay. But there is a washout period, kind of detox period, that you have to do there in between, during which time the patient will probably experience some withdrawal symptoms. So you may need to kind of manage those. And that's easiest to achieve in a controlled setting, right? In a hospital, prison, rehab center, something like that. More difficult to do at home. Methadone, switching from methadone to buprenorphine. So that's complicated. And there's different things put out there about how to do that. But the standard guidance that I've seen is that you try and wean the methadone dose down to 30 or 40 milligrams a day, and then you stop, and then you wait till you see withdrawal symptoms that are objective, and then you can start buprenorphine dosing. There's been other things out, like microdosing with buprenorphine, where you start a really tiny dose of buprenorphine and overlap that with the full agonist. That's been talked about, but the standard approach would be to just really try and go down to a dose of methadone that's 30 milligrams or less a day, and or go down to where the patient starts to exhibit withdrawal symptoms, and then stop, and then switch to buprenorphine within a buprenorphine induction process. From methadone to naltrexone, you got to completely come off of the methadone, or else you're going to precipitate withdrawal. Right. So again, you have to go through that period of time of tapering the dose, and then detoxification, so medically managed withdrawal probably, before you can start naltrexone. Naltrexone to buprenorphine, not terribly complicated. Basically, you just want to wait for the naltrexone to metabolize out of the body before you start the buprenorphine, right? So for oral naltrexone, which really you're not using usually for opioid use disorder, more for alcohol use disorder. But if they're on the oral one, you wait a day, at least 28 days for extended release naltrexone to wait, and then you can start with the buprenorphine. You might need to use a low dose because the tolerance may have decreased over the period of time the patient was being treated with naltrexone. Same thing with methadone, right? You may need to use a lower dose of methadone, and you want to wait till that sort of period of time for the naltrexone to kind of have worked its way out of the system, so it's not occupying the receptor and blocking the medicine you're trying to give from working. So some of these are complicated, some of them are not. The most difficult ones typically tend to be switching from buprenorphine or methadone to naltrexone, or switching from methadone to buprenorphine, right? That tends to be the most complicated ones. There's a question in the chat about, let's see, I missed one? No, okay. What's my thoughts on starting someone on MOUD who's been abstinent for a long time but is now experiencing cravings? Yeah, so I think I've done that. I think sometimes it's the right thing to do. I mean, I think, as Katrina was talking about before, some of your decision making depends upon the severity of the opioid use disorder they have. But if this is somebody with a history of overdoses and injection use and using heroin and fentanyl, and who's been incarcerated, right? That's sort of a forced abstinence. It's not like they were really in recovery. Well, it's not. They were not engaged in treatment. They were not, really engaged in a recovery program. I'm assuming from what your question is saying. So, so that person's probably a pretty high risk, right? Actually, like when somebody's decreased, or somebody who's been incarcerated, right? Their tolerance may have evaporated. They may have received no treatment during that period of time, so they haven't really built the skills and the social network and everything that would help them stay in recovery. They were really pretty high risk for overdose and all kinds of negative outcomes. So yeah, I mean, I've done that before. I mean, if somebody comes in, and they says they're having intense cravings, they're afraid they're going to start using again. You got to make sure that they have a well-established diagnosis of MOUD, right? So you need to know that for a fact, right? Because in this instance, you're describing, their drug screen is probably not going to have any opioids in it, right? So it would be good to have, previous treatment records or some sort of information, collateral information from someone just to verify, right, that this is in fact accurate, but if it is, then yeah, I mean, I think sometimes it's the right thing to do to prevent a return to use. So buprenorphine is a partial agonist. How can it be misused? Similarly, it's kind of similar question. The plug picture, buprenorphine as a surge protector, can it be misused? Yes, it can. And it is. It can be abused, misused, diverted, etc. Right? So patients will sometimes take more than they're prescribed. Sometimes they will divert it to other people, and that they know that they've used with. It's misused. Sometimes it's injected, snorted, whatever you can imagine, right? In terms of ways of misusing a medication, but there's a big caveat to that. Because it has that lower level of intrinsic activity, there's less of an intoxication. Like there's less of a feeling of subjective feeling of it being high or intoxicated, especially in patients who have tolerance, right? And there's less risk of respiratory suppression than full agonists. So substantially less risk of respiratory suppression as compared to heroin, fentanyl, oxycodone, all kinds of different things. So that's the first caveat, is that it doesn't really produce many of the same risks as using other opioids illicitly, and it doesn't have the same subjective high kind of feeling for most patients that other opioids do. In my experience, I don't think I've met really anybody that I can think of who really had buprenorphine as their drug of choice. I've encountered lots of people who've used buprenorphine illicitly. It wasn't prescribed to them, but they were taking it anyway. You guys probably have too. But that's usually sort of either something like a last resort sort of thing, or the patient is knows that this can reduce withdrawal symptoms, and they're trying to self-treat their own withdrawal. And even occasionally, they know that it's safer, and they want to do this because they think it might be safer than taking their chances on whatever they've been getting from the person who's selling them drugs, which might be fentanyl, right? So I've heard that from patients too sometimes, because we've had some people come here who've been using buprenorphine on the street for the last weeks or months or something like that, after having a period of time of using heroin and fentanyl and all this stuff, because of that, because they thought it was safer, correctly thought it was safer, and really kind of, it was a gateway to them to treatment, right? So is it misused and diverted and abused? Yes. Is that as dangerous as using other things? No, it's not. And that's not usually the person's first choice for drug of abuse. And in some instances can even be a step toward treatment. And we kind of talked with this already. Katrina added in the chat that, this is a good statistic for people with overdose released from jail. Risk of overdose is 100 times higher in the first 2 weeks after release from jail. So yeah, MOUD could, definitely agree. MOUD could be life-saving for that person. And so how would you work with a patient who wants to taper as soon as possible? Well, we talked about this a little bit, but we talked about it more kind of in the abstract, should you do that or not? So I guess I could talk about what I would actually do with a patient. So first thing would be to provide education about the risks, especially the mortality data. We know that if you do this, especially if you do it too soon, you have a substantially higher risk of overdose and death. So really, really underscore that. Generally, I just flat out kind of discourage this. I just, say, I don't think you're ready for this. I mean, we'll work together and collaboratively come up with a treatment plan, but I don't think that this is the right time for you to do this. And then kind of figure out why they want to do it, right? Is it they don't think that this is quote unquote real recovery? They don't think that their peer group is going to accept this. Like maybe they're in a support group or a 12-step group or something like that, who's really not in favor of medications of any kind, possibly, or specifically for opioid use disorder. So is there an external pressure, right, that they're facing, right? A spouse or partner, somebody who doesn't want them on medication? Is that what's driving this? Is it, that they don't understand how the medication works, right? And you can just kind of educate them about that and the evidence base to support its use. Is it internalized kind of stigma, right, that they've had, from exposure to folks in the past? Is what's going on, what's driving the decision? I think that's a good question. And if this is all, if they're still, like refusing to do, what we would recommend, and then in that case, I would at least increase the level of monitoring that they're having. So have them do more frequent drug screens, more frequent visits to the clinic, and increase the amount of support, right? So maybe they're doing more meetings, more contact with their therapist, right? And also, right, you can talk about switching to a different MOUD. So right, if they're opposed to one, right, maybe you could switch to a different one. And that might be an option and still provide some benefit to the person. So really, but I think it's something you want to try and encourage patients to not do, given the risks that are associated with that. Uncover why they're doing this, or why they want to do it. See if you can help them address that, whatever it might be, whether that's sort of an internal value or stigma or something that they have, or it's external pressure. See if you can figure out someone to help them address that. And then, just, be as supportive as you can if they're insistent upon coming off the medications sooner than you think that they should. And like I said earlier, I think many times when I've had in situations like this and we start to go down, patients start to get, they start to feel it. In my experience, going from 16 to 12 is usually fine. 12 to 8, some people start to notice that they're having more cravings, and then when we get below 8, really, the patients really seem, talking about buprenorphine doses, really at that point, patients start to notice a lot more, sometimes withdrawal symptoms, but craving and mental obsession, things like that. So, and then they decide, right, that they want to go back up. So the other thing I do here is sort of, if they're insistent upon coming off the medication, I'll try and convince them to go slowly, right? Over the course of weeks to months, not, days to weeks. Giving them, because that'll give them more contact with other treatment providers, more time in treatment, more time to reconsider, more time to, not be on, illicit opioids, right? So that's kind of the general approach I've taken. So anyway, that I think is it for me.
I think we might have time, but I did have one question that was sent to me.
Yeah.
Your thoughts and suggestions for having conversations about the benefits of MOUD with someone who has used methadone and buprenorphine but did not have a good experience with MOUD.
Okay.
So in this case, they would not have gotten what we would consider quality care. And so how would you talk to them or about that?
Well, yeah, I think the first thing I would probably do would just be find out more about what happened, right? So sometimes the thing we hear is they don't like buprenorphine because they tried it and it made them sick, right? So that often to me says that they didn't have a proper induction. And or they were using it on the street illicitly, and they had precipitated withdrawal from taking it incorrectly, right? So that's just kind of finding out, was it something like that that's we could be fixed with, like, just teaching them about how the medication works, and doing, maybe modifying the induction process so that it will go more smoothly this time. Is it similarly with naltrexone? That same sort of thing can happen there, right? You can have precipitated withdrawal if it's begun incorrectly. Finding out more about the specifics of that, providing some education about, once you've identified what went wrong, what could be different this time. There's a whole host of things that could have gone wrong. not knowing what it was, it's hard to say specifically what could be done. Maybe it was, with the methadone clinic, maybe it was the logistical barrier. Maybe that was their bad experience. They couldn't make it there. So is that a problem that can be solved for this person? So yeah, really finding out more about what went wrong and seeing if there's a way to work around that. And listening too, I think of is this like stigma again? Is this sort of like the patient's negative perception generally of MOUD, and they're just presenting it as a failed treatment attempt before. So